With just a few minutes, give it about a minute here for folks to join us. We have a good amount of people jumping over, so I think we can go ahead and get started. So on behalf of the American Heart Association, I'd like to welcome you to this session, Substance Use and Advanced Heart Failure, Breaking Barriers to Advanced Care. Throughout this session, you'll have the opportunity to submit text questions for our speaker using the questions feature on your control panel. You may send in your questions at any time, and we will review the questions during our Q&A at the end of the presentation as time allows. To access live closed captions, please click on the closed caption button found on your screen. All sessions will be recorded and available shortly after the event. It is my pleasure to welcome our speaker for this session, Dr. Deborah Meyers, who is a section head of advanced heart failure and transplant cardiology at Oregon Health and Science University in Portland, Oregon. As a reminder, our full speaker bios can be found in the event lobby. And with that, I'd love to turn it over to Dr. Meyers for her presentation.
Okay. Can you get my slides up, Ali? Okay, great. Well, I want to thank everybody for your attention and for the invitation to be here. And Kelsey and your team, thank you very much for making this all happen. This is an issue that I haven't heard a lot of talks about, and I thought that it would be really important to discuss and really start a conversation amongst this group. And so not only do I want your questions in the afterwards, I want your comments. I'm really interested in hearing your thoughts and your ideas because we don't have any national standards regarding substance abuse and abuse disorders, how it relates to advanced therapies. Okay, so I want to talk a little bit, and I think I got really involved in writing this talk after I was at one of the meetings amongst this group, and I was mentioning how much methamphetamine cardiomyopathy that we see here in Oregon. And it turns out that we're like #1 in methamphetamine, yay, Portland. But it's something that is really a big problem for us. And so then on that basis, when I was making that observation, my colleague said, why don't you give a talk on it? So here we are. So methamphetamines, as you probably are aware, are extremely addictive man-made stimulants. They are both cheap and they are readily available. Again, we have proof that, or documentation that between 1919 and 2020, Oregon had the highest meth use in the United States. Meth at this point is involved in 49% of all overdose deaths currently because a lot of the methamphetamine and is now laced with fentanyl, and it's an enormous problem. The price of meth, and those of you who don't use meth probably don't know this, but it's dropped to as little as $5, which will basically, for $5, it'll provide a 3-day high. And the potency has really increased. Anecdotal reports suggest that methamphetamines overtook heroin as the drug of choice amongst Portlanders experiencing homelessness as early as 2007. There are strong mental health impacts of chronic meth use. And a number, I'm not going to go into the statistics on this, but there's public health records suggesting that psychiatric emergencies that involve meth are very, very common and on the upswing. And as you all know, and I could give a separate talk about this, there's a very distinct cardiomyopathy that's methamphetamine related. It's associated with meth use, and we see it here at OHSU on almost a daily basis. 49 million Americans age 12 and older have a substance abuse disorder within the last year. That's 1/6 of Americans. The leading cause, it is the leading cause, substance abuse, of accidental and preventable death. Fentanyl is the top cause of death for those in the 18 to 49-year-old age group. Alcohol is the third leading cause of preventable cancer in the US. and 14.5 million individuals had an alcohol use disorder in the last 12 months. And of course, this is only a few of the addictions that come our way as practicing clinicians. There's other addictions. There's alcohol, there's prescribed drugs, there's other stimulants, ADHD drugs, food, cannabis, gambling. People are addicted to the internet, sex and love, shopping, video games. It goes on. And I pulled a couple slides which I thought were really interesting. And this was derived from some national data, and it was published in 2020. And what this is showing is that when they look at a population of people 12 and older in 2019, only 39.9% of people are using no substances whatsoever. So that means that 60.1 people, 0.1% of people are getting high on something or other. Now, this doesn't necessarily define as substance abuse, but it sure means that a lot of Americans are getting high. And when I look at this slide, it reflects what I see in my clinical practice, but it also reflects the fact that I think life is very hard for people. And I really approach the issue of substance use disorder with a lot of empathy and sympathy. When you look at the definitions, and again, these are a little bit fluid, how we define substance use versus substance abuse, but with this survey, they actually defined that of those 60.1%, 7.4 of them actually would meet criteria for a substance use disorder. We're going to talk about that a little more. I'm going to tell you about two cases that we've had here at OHSU, and this was sort of early to my coming to OHSU in 2020. I came to OHSU just in time for the pandemic. And here are a couple of the patients that we met with our team. The first patient is KH, 27-year-old female, mother of a young son. She was diagnosed with meth hep in 2018. And had an ejection fraction of 10% at that time. We met her early in 2020. She reported a greater than 3-year history of chronic meth use. She was seen by our impact team. That's our group here locally that intervenes on substance abuse patients in the hospital. And she was discharged on guideline-directed medical therapy. She followed up briefly as an outpatient, but then she was lost to follow-up until 2020 when we met her again. She came in to again in 2020 in May, and her guideline medical therapy was reinitiated. Unfortunately, she was able to go home, but managed very briefly as an outpatient. It was readmitted in cardiogenic shock and very, very sick a short time later. We placed a VAD in October of that year after much deliberation amongst our team because she was actively using meth when she came back in for that admission. She was diagnosed with a severe substance abuse disorder and only achieved sobriety in the hospital. Why did we go ahead and implant her? Well, she was young. That tugged at our heartstrings. She had a young son. She started attending NA meetings virtually in the hospital. She engaged with our impact team, and she particularly engaged with a peer support person that was provided. She had great family support. She had parents, the father of her child. Everyone was involved. She appeared to be motivated to live for her family. She had lots of things to look forward to. She worked very collaboratively with our team. She went through a lot of the things that we put her through with a great deal of grace and fortitude. She impressed us, and there was no other option. Death would have been inevitable. Now, she did beautifully. She remained clean and sober. She got involved in intensive outpatient therapy and substance abuse treatment. She was our poster child. She was amazing. We ended up transplanting her in 2022. She's a model patient, a model mother, model citizen, very involved in the sobriety community. You couldn't ask for a happier outcome, okay? Now contrast it to this scenario. 37-year-old, this is SD. He was a male smoker, the father of 2 children. One of his sons had autism. He had a history of meth hef. He reported greater than 10 years of use. He was diagnosed again with meth hef cardiomyopathy in 2019. He presented to us in 2020. In July of that year, he had an embolic thrombus to the LAD. He was very decompensated. He was on dual inotropes. He had reported at the time that we saw him that he had achieved 6 months of methamphetamine sobriety, and his use went way back to the age of 16. He was assessed by our impact team as being a very motivated patient. He was willing to engage in treatment. He did engage in treatment in the hospital, and we ended up implanting an LVAD in July of that year. Why do we do it? Well, because he had achieved some sobriety. However, he was deemed at high risk for relapse on both our SIPAT. I'll talk a little bit more about that. And he was deemed an overall poor VAD candidate by that same Stanford integrated scale that we use. And I'll speak about that in a minute. He did appear motivated. He worked very collaboratively with the impact team. He had a family to live for, his children. He was assessed to have good social support with his wife and mother. He had no other options. Once again, death would have been inevitable. And his LVAD course, though, unfortunately, totally different outcome to the first patient, complicated by poor compliance. He relapsed, this time with IV heroin, oral opiate use. Then he developed a chronic MRSA driveline infection. He had septic emboli. He developed candidemia. His social stability it became more of an issue. He had a brief loss of housing, and he had periods where the patient was completely uncontactable by our team. The outcome, has been very bad. This outcome is related in a lot of suffering, multiple additional hospital stays, significant efforts on the part of our coordinators when the patient wasn't contactable, moral distress experienced by the whole team despite thousands of hours of care. And after I was writing this talk, I was on call last week, and unfortunately, this patient had a VT-VF arrest at home, came into our ER, and he had, pus coming out of the drive line. He had fistulas of his infection through the lateral chest wall. He did not survive his code, and I was there to pronounce him dead and comfort his very distressed family. So we have, on one hand, this really great outcome, and on the other hand, this really terrible, distressing outcome. So one of the things that's very clear, and now I'm going to step back from those cases and talk to you a little bit about, the fact that there is a lack of homogeneity against centers nationwide. And I would really like to start a dialogue about about the fact that we should have more consistent criteria amongst our centers. The selection criteria for advanced heart failure therapies does vary between centers, and it sets the stage for a whole host of medical, ethical, and legal issues. 24% of the states in the US have legalized cannabis use for recreational use. Centers can turn down candidates for medical reasons, infection, malignancy, BMI, a whole host of things. But centers also have to consider substance abuse disorders, noncompliance, lack of social support, inability to adhere to complex medical regimens, and the ability to follow up in clinic, as well as financial stability. There are no national standards for these psychosocial issues. Programs often diverge with respect to categorization of substance abuse disorders, length of acceptable periods of sobriety requirements before they go on to advanced therapies, and modes of relapse management. This can result in unequal access to heart failure therapies and system gaming. So a patient will say, I don't like your rules. I'm going to go somewhere else where the rules are are less strict, or maybe they don't know about my substance abuse, and that's a problem too. Okay, so we were very interested in getting our group together and trying to come up, and again, I don't have the answers here. I'm telling you what we are trying to do in our program. And we are not at the finish line yet, but we are really working actively on this. We're trying to develop rational, transparent policies that with a strong ethical framework underpinning what we do. We want the policies to be equitable. We want policies that will distinguish between substance abuse and substance use that is supervised medically. We want to define abstinent requirements clearly. We want to define relapse policies clearly. And we want transparency with our patients, and we want education to all members of the team and the community so that patients are fully aware of the obstacles they face at the outset of becoming a candidate for advanced heart failure therapies. Substance abuse disorder has been a challenging and sometimes contentious issue within our group. We do recognize the need for consistent and transparent policies. We need to recognize that addiction can be to both legal things and illegal things, and that becomes even more tricky. We have to define that, and in the beginning of this, we actually sat down and reviewed all the tools and all the definitions of substance abuse and substance use, and to try and tease this very complicated issue apart. What we are doing now is we're using two tools. We're using both the SIPAT, which is a Stanford Integrated Psychosocial Assessment tool, which breaks substance abuse disorder into two categories: use disorder and risk for relapse. The second tool that we're using is the DSM-5, and that's the Diagnostic and Statistical Manual, 5th edition. And it defines substance abuse disorder as meeting 2 of 11 criteria, but it also helps us because it provides a severity framework when we're trying to get to distinguish that fine line between substance use and substance abuse. So, and then we're trying to also standardize our language around this. And for example, we're using early sobriety as less than 3 months, 3 to 12 months is an intermediate sobriety, and sustained remission is greater than 12 months, and stable remission is greater than 60 months. So we're now at least speaking the same language when we're discussing this problem. We are aiming to develop policies will create, again, rational and standardized framework. We want to reduce inequity. We want to improve consistency and reduce arbitrariness and bias. We want to provide not only good outcomes with respect to survival, but quality of life. We want to respect the voices of the entire team. And especially now that we're thinking about VAD therapy, and we know that therapy has improved so much after the last decade that it actually can confer a pretty good long outcome. We want to recognize the vast resources, though, that VAD therapy requires, and I'm going to go into this in a minute. We want the policies to be consistent between what we see and what we require from a stable ambulatory population and those presenting as critical cardiogenic shock. And that's a much more difficult situation because these patients will present in cardiogenic shock. We're trying to tease out, often these patients are intubated. They're not in a situation where they can go to, they can enter, any kind of substance abuse treatment disorder. And we have to make decisions with fairly incomplete knowledge. And that is really difficult. So one of the issues that came up in our discussions that I think is really important when talking about substance abuse is we really have to be careful that we are using our judgments without being judgmental. And there is a difference between these two things. we are trained as clinicians and as human beings to make good judgments. It's something you do every day. What am I going to eat today? Am I going to exercise? Am I going to get high? These are all judgments that we all make. So judgments are important for us, and our team must be able to make them collectively. But judgments really refer to the ability to make considered decisions on come to sensible conclusions. It has to do with the process of forming an opinion or an assessment by discerning and comparing. Judgment refers to the ability to make the right decision based on experience, circumstance, information, knowledge, and wisdom. Judgmentalness, on the other hand, is characterized by a tendency to judge harshly without empathy. It's often about making decisions about the value of a person or people based on limited information. The judgmental state of mind is a rush to judgment without reason, making a decision without really understanding that person's situation. And the key to not being judgmental is to recognize that people can agree to disagree. When discussing the differences of opinions, you may find that you have more in common than you thought possible once you dig into these areas. But this is on selection committees, these are very important distinctions to make, I believe. Now, what's the definition of addiction? It's defined as a chronic, relapsing disorder characterized by compulsive drug seeking and use despite adverse consequences. It's considered to be a brain disorder because it involves functional changes to the brain circuits involved in reward, stress, and self-control. These changes may actually last a long time after the person has stopped taking drugs. And that's from Nature Neurosciences. And I think it's a really great definition, because key to this is the fact that it's a chronic relapsing disorder. We decided to take our discussions, and our discussion includes our whole group, coordinators, doctors, our psychiatrists, our social workers. We want everybody's opinion. And we decided to start with what we thought was low-hanging fruit, which was what are going to be our standards when we have a stable ambulatory population, not a big emergency like the 2 patients that I described to you before. We felt that all patients should be assessed with both DSM-5 and the CIPAT definitions for describing the presence or absence of a substance use disorder. For tobacco, we require 6 months of abstinence. This is particularly for transplant, confirmed by negative cotinine and anabasine testing. I'm not going to go into that in detail right now. Alcohol, all of our patients with alcohol use disorder are going to be asked to abstain, and we are going to do PEth testing, and we're going to demonstrate 6 months of negative PEths. A PEth greater than 200 will be a flag for more intensive monitoring. Quarterly monitoring of PEth on the wait list, and we're going to employ random verification. Cannabis is a much harder thing to test for because of the nature of the test itself. Again, we can't define cannabis use disorder with the CIPAT and with DSM-5. Again, the testing is more challenging, and what we're trying to do is tease apart a genuine cannabis use disorder and not create barriers for candidacy for people who are occasional recreational users. Now that may change with the new British Medical Journal articles that came out this week suggesting, the increased more cardiovascular mortality for patients that actually use cannabis. But again, these are very preliminary reports, and we have to think about that as a community. Now, the ethical principle of justice is really important here. And there is no consensus about what constitutes fair distribution with respect to scarce resources. In some ways, the ethics of organ distribution are more straightforward than with mechanical circulatory support, is that there is an explicit and implicit ethical obligation to the donor and the donor family, as well as to the patient that we're advocating for. And that is like one of the weirdest and most interesting things about transplant, that we are obligated, because we have to honor that gift that the donor made to us, we are obligated to use it and give this organ to patients that will cherish it and take the best care of it. Our group has been much more comfortable with setting defined boundaries around transplant candidates than mechanical circulatory support. And I think that this underscores a view that mechanical circulatory support is a mechanical thing. It sits on a shelf, it's made in a factory, and it represents a less limited resource in theory. However, I would posit that it represents a resource-intensive exercise on the part of the patient, the family, and the care teams. I cannot tell you how many thousands of hours went into trying to support that second patient that had the disastrous, sad outcome. Survival with mechanical circulatory support has improved. It's about 85% at 1 year and about 60% at 5 years. Pretty darn good. This area has represented a more contentious issue, as there is a sense that a much lower bar is acceptable with respect to substance abuse boundaries and other medical criteria. But I'm pointing out to you, and I'm underscoring this, that the bad care is resource intensive. There are very few hospitals in our states that actually even admit these patients. So we do a lot of patients that are in the far boundaries of our catchment area, which is hours and hours and hours away. And, you know, when they present to these remote centers and they need an admission, we have to fly them in. They aren't able to be cared for in their local communities. So we're trying to carve out what are the boundaries of too much risk for in the setting of mechanical circulatory support for patients who are choosing to use substances. And how do we make decisions about an individual's likelihood to relapse in such a way that it would limit their ability to engage in complex care when the outcome is unpredictable? I mean, no one can predict relapse. And in most cases, even substance abuse experts underscore that relapse is part of this disease, and that it's an opportunity for patients to learn from the relapse, to develop new skills, and reestablish their sobriety. That's great, but how do we apply that to advance heart failure therapies? So these are very tricky, dicey issues. Recovery is not an event or a time-limited goal. It is a series of changes across multiple domains of that individual's life that need to be maintained lifelong. That's why it's so complicated. Given that it's a relapsing disease, we felt it was necessary to adopt a transparent second chance policy. So we have developed a policy that if a patient begins a period of abstinence for at least 3 months after being listed, demonstrates upon random verification that they've engaged in substance abuse, they will be delisted, but eligible for 1 second chance, not forever, but one time. This will be a second period of abstinence confirmed by ongoing verification. They'll once again be considered a transplant when a 6-month substance-free period has been achieved. The patient should be compliant with physician orders and any treatment recommended for substance abuse disorders during that second period. And we hope, and again, we have not developed strict criteria for when we are going to insist on substance abuse therapy, because that comes in many forms too. And again, that's going to be very difficult if, say, a patient is stable on methadone. So, and we would consider that those patients might be, if they're stable under the care of a treating physician, a methadone patient could be eligible for listing. So there are so many nuances to this, and this is why I'm really interested to hear what y'all think. One issue that was identified with both of the 2 cases that I talked about was that if we had not intervened urgently, death would have been inevitable in both cases. This creates for doctors and healthcare teams, VAD, transplant, everyone involved, a tremendous imperative to intervene. Are there boundaries? What are the boundaries? Should there be boundaries? We are trying to work through the process of how to best create boundaries while still providing high-level patient care. And this is very challenging. And for many people, it can represent a personal ethical dilemma. Although the need for boundaries is universal, how we use those boundaries, how we create them and apply them is context dependent. So if a complete lack of boundaries is at one end of the spectrum and patient abandonment is at the other, where are our programs going to fall out? What are we comfortable with? And that may be something that is really a local decision. Unfortunately, this is a challenging task that varies from one individual to the next. So even within people, there are very different feelings about this, depending on their own needs, their own value systems, as well as, you know, the circumstances in which they're trying to set the boundaries. Family, institutional, cultural support. It's very complicated, but it needs to be talked about and more. The combination of stakes, high stakes, and then that sense of urgency when we're with the critically ill patient could easily put anyone into what's been called a system one state of mind. This was described by Daniel Kahneman, who recently died. He was a Nobel Prize winning behavioral economist. And he described two modes of human thinking which impact our decision making. System one is fast, emotional, impulsive. We've got to do something now. System two is deliberate, thoughtful, and more rational. His advice: step back and assess the immediacy of the situation. And the best thing one can do when making difficult choices under difficult circumstances is simply ask, what does the data say? What do the outcomes look like from a programmatic perspective? And this needs to be included in your thinking. All of us are going to have anecdotal anecdotal evidence. Like I could point to the first case and say, well, we'll do lots of substance abusers. They do great. I could look at the second case and say, lots of, here's an example of someone who did badly and had a really rough go. And, when you see, and suffered and then ultimately died a pretty awful death. And how does that individual bias, how do we bring that to the table? And how does that influence our decision making? So a sound decision specifies that there's a connection between the means and the outcome. A rational decision maker will choose the best possible outcome that involves the least amount of resources. A rational individual will consider many of these factors, and these may include, but are not limited to, prices of treatments, effectiveness of the treatment, compliance of the patient, pain and satisfaction of the patient, rules and regulations around the healthcare system, and many other factors. Rational individuals try and maximize their outcomes. But the best doctors and decision makers are still susceptible to error. These mistakes stem from a wide array of problems, particularly the fact that the human mind is limited in its ability to calculate multiple probabilities, as well as occasionally the tendency to lapse in judgment and lapse in memory. Doctors may be influenced in their choices due to sympathy or lack of sympathy. And so your own human emotions and how you experience things ultimately may hurt or help the patients. Medical review boards are generally set up with a single clinician presenting to a selection committee, which is a group of peers. It's an advocacy system. And if you have one patient that you really believe in, you take them to the group and the group says, we can't do this patient. There are often a lot of hurt feelings and a lot of strong feelings. So there needs to be a collective responsibility that applies to the medical review board, which establishes the mechanism for approving patients for advanced therapies. And the aim is that the group comes together to achieve what's best for the patient. Often a single decision maker is not enough. And I really think that if your group can have these nuanced discussions, acknowledge the difficulty of it, you can come together and make really good decisions. This creates safety in many, many ways for the group, that there's shared decision making, but it can create discomfort. but there are always group dynamics at play. Sometimes the coordinators feel that they don't have as much of a voice, and they probably should, because I think about our VAD coordinators in the case of both of these patients, and and they just they went to they went to such great lengths to support the patient that did well and the patient that didn't do well. The members of the group can vary widely in their risk tolerance, and they can have other conflicts of interest which may or may not be aligned with the best outcome of the program of the patient. Some people want to go to meetings and they want to say, oh, I did this many VADs this year, I did this many transplants this year. But in some ways, a better measure would be, I have this many patients doing really well with VADs or transplants, not just volumes. And that's always been my own personal thing. But anyway, and again, I think we're getting short on time. The team should comprise professionals from different disciplines coming together. The team has to work collaboratively. Everyone has to apply their special skills. There needs to be open communication, shared goals, and respects for each member's expertise. A healthy team has a shared vision, clear goals, and equality amongst the members. But hazards do exist in groups. One faction can be dominant over another. There can be professional loyalties and tribalism, and the imperative for increased volume may influence decisions in a perverse way. This can be overcome by effective leadership, and this is something I struggle with all the time, how to promote this health amongst the team. The stakes are very high, okay? Our time is going short, so I just want to say that the significance of these decisions we make for these patients are huge. It can be life-altering. But on a broader scale, the decisions can result in health system changes, and it is really important that we weigh decisions about offering therapy when substance abuse disorders are involved. And we may have to make these hard choices with limited information, resources, and knowledge. And it's impossible to predict the future. And yet somehow we're expected that these decisions are highly calculated and accurate. All I can say is I think I have a lot of trust that the people in our group and selection committees across the country really are so dedicated to this job and taking care of this crazy disease that we do take care of. So one of the things, and I'll sort of wrap it up with this, when we consider any mode of advanced heart failure therapy, we have to think about two things. Is a patient's quality their life quality going to be improved, or is the quantity of their life going to be improved? It's not such a good deal to get one without the other. And then we have to focus on three separate questions. Will the patient benefit from this highly complex surgical intervention that requires lifelong ongoing follow-up with respect to their quality of life and their quantity of life? Does the patient meet our medical criteria with respect to medical fitness to endure this physiologic insult sufficient to derive these benefits? Is there sufficient capacity, insight, supportability, and resilience to collaborate with the team and to benefit? The question is never, is the patient valuable enough to justify therapy? So I have more questions to pose to you than answers. I'll wrap up by saying there's no cure for advanced heart failure therapy. There's trade-offs. You trade one set of problems that you have with advanced therapy for another set of problems that you acquire with advanced heart failure therapy. We want our patients to live longer and live better with their new set of problems. We want to support them with those new problems. Life is complicated, both for our patients and for the huge responsibility that we embrace taking care of these people. Please have nuanced discussions with your team about substance use and abuse. And this is a very important factor given how common this problem is in our society. So I am really interested to hear any comments or experiences that you have on your end. And thank you so much for your attention.
Thank you so much, Dr. Myers. That was a wonderful presentation. And I would welcome if any of you have comments or you'd like to ask any questions, you can raise your hand and we can unmute you, or feel free to enter them in the chat or in the Q&A box as well. But I think one question that kind of comes from this is, I guess it doesn't really apply necessarily just to the substance abuse population, but also kind of generally to the population facing other socioeconomic barriers. But what are your institution's policies about caregiver support for advanced therapies? And what support do you offer to patients to overcome that?
Well, at our program, we offer a lot of social support, and we actually require a lot of social support. In most cases, our preference is to have a caregiver full-time for 1 month with our VAD patients. They have to stay locally, and 3 months for our transplant patients. We go to great, and we like to have a backup caregiver because occasionally the caregivers experience a lot of stress too, and they will need a backup. We have done people that do not have that backup, but it is not our preference. We have for people that do not have the financial wherewithal to finance staying here for 1 to 3 months. We do have some housing available here that's on short supply, but we do our best to carve out everything that we can to support our patients. And then we have also developed a share care. And I think this was mentioned by the previous speaker, that share care systems down in Southern Oregon, so that patients can, that we have qualified, people that we've trained, that we can do video visits so that they don't have to be, especially with our VAD patients, that they don't have to come up to Portland all the time, because that can be quite onerous, expensive, and time consuming.
Thank you. Another question we have is, how do you integrate palliative care in the population?
We integrate them. We have a very integrated program. We're very lucky in that regard. When I came here to restart the program 5 years ago, it was something I insisted upon. The palliative care team is, we have upstream palliative care. So they meet with the patient when we're considering any advanced heart failure therapy, be it VAD or transplant. They weigh in on the patient's readiness to address complications, on their resilience, on their understanding of their disease. And they help patients try and work through the process of, providing advanced directives, working through that. What would they want if there was a complication? And then our palliative care team will loop back if there is a complication to support both the patients and the families. So I would say our approach is very integrated from the very beginning of our evaluation process all the way until the patient, even many years after their journey, after their initial implant or transplant, our palliative team is available for them.
Do you have a dedicated palliative care provider specific to your heart failure team, or
It's a team of people but they are well represented. And at every selection conference, our palliative care providers are important contributors to our discussions.
Great, thank you. Looks like we have a question from Roy. He asks, for substance use disorder, what is your experience regarding 30 versus 90-day programs?
Are you talking about like your rehabilitation programs? Is that all right? So the answer, look, the real answer is I don't know. I think that what we're aware of is, first of all, mental health services in Portland. I think we rank very low in the rankings when you look at national availability of mental health services. I would say substance abuse programs are very similar to this. It is hard to access these programs. There are huge differences between programs and the quality of programs. There's intensive inpatient substance abuse programs. There's intensive outpatient substance abuse programs. And then there are more informal programs, like NA or AA, that are free to all comers. And so, the answer is, I think, some people like the 12-step approach. Some people do not like the 12-step approach. Some people find it a turnoff, and there are alternates to that. But one of the things that I did when I was practicing in Texas is when I was running a critical care group, one of my requirements for passing for med students and early medical student trainees is I said, have you guys ever been to an NA or NA meeting? And most of the people said no, because they were, busy medical students, interns, residency. And I said, you can't pass this until you go to a meeting. You're not going to pass my rotation. And that's an hour long. But how are you ever going to talk to patients about substance abuse if you don't know what goes on in a meeting? So I would really encourage everybody here who's never gone to a meeting to join an online meeting, to show up at a church where there's a meeting. There's like 27 of them every single day, I'm sure, in your community. Just get onto the website, find a meeting, either go or listen remotely. It will not be boring, I promise you, and you will learn so much about it. And that's again, one of my other suggestions.
That's great. Thank you for that great kind of real world advice. And I think that's about all the time we have for today. And we welcome you guys all to join us for our final session, which is going to be a Q&A panel discussion for Dr. Meyers and Dr. Yarnov. We'll have some guided questions that we'll be asking them about kind of their practices and how they've built their programs, as well as welcoming all of your questions as well. So in order to join that final panel discussion, you can exit this session and return to the lobby using the menu at the top of your screen. Click on the sessions tab and then join that session. It's scheduled to start at about 3:45 p.m. So you have a few minutes to grab a drink of water or whatever you need to do in the meantime. But we have also posted a link to join that session in the chat as well. So we hope you'll join us for our last session as we wrap things up today, and we'll see you soon.